Okay, so as promised, okay, as promised, we are jumping right in again to wrist, hand, fingers, and thumb. Again, anatomically, a lot of the stuff is still very similar to the foot and toes. Some terminology changes. Obviously, the mechanism of injuries will be slightly different for this one, but we are moving and grooving. Okay, so when we're thinking about the bones of the hand, very similar then to, again, the bones of the foot, we can classify them in a couple different sections. Carpals, metacarpals, and phalanges. Of the foot, carpals would be tarsals, metatarsals, phalanges would still be toes. So thinking about what these look like, again, I have some pictures. If we think about one being the thumb and five being the pinky, we also have to think about things in anatomical position. So if we're thinking anatomical position, someone's standing palms forward to you. On the medial side, we'd have the pinky, and on the lateral side, we'd have the thumb. So even though big toe is toe number one, pinky toe is toe number five, with the hand, thumb is number one, pinky is five, and that order kind of changes. And if it's medial to lateral, lateral to medial. So still, one will be the big one, five will be the pinky side. The groups collectively are called phalanges. So you'll have one pinky phalange, but it's actually three separate phalanxes. So we just call those phalanges, the plural of phalanx, phalange. Regina Phalange, if you watch Friends. If not, just fingers. Okay. So if we think about our finger bones being our phalanges, our metacarpals will be the long bones. So of the foot, the long bones of the foot, metatarsals. In the hand, metacarpals, the long bones of the hand. Now, those will be these ones right here. If we're thinking where the carpals will be, they are tiny, tiny, tiny bones. So there are 8 of them in this tiny space here, 2 rows of 4 bones each, making a total of 8. So we will talk about 2 or 3 of those 8. Not super important that you remember all 8 of them, but we will talk about 3 of them a little bit more. Now, if we think again about how many bones there are, there's got to be a lot of ligaments to hold these in place. So on the fingers, there will still be collateral ligaments preventing against a varus or valgus stress, depending on what direction you're moving and moving it towards the midline. The thumb is very different, though, from the big toe, because instead of just hinging, you have the ability to oppose your thumbs, crossing like this. Thumb abduction, moving away from the midline, adduction, coming back down. And that's confusing because some people would think that's flexion extension. It's actually not. So if you think about flexion of the thumb, that would be coming forward this way. So if you're looking straight down, this would be thumb flexion, and this kind of moving back this way would be thumb extension. So again, abduction, adduction, opposition, and then thumb flexion, thumb extension, moving back this way. I don't have a lot of thumb extension naturally, but the thumb is a saddle joint, so that's what controls how it moves. We should not see a ton of motion in our carpals. They're shaped really awkwardly. They are irregular shaped bones. Again, for 8 of them to be here, they're very tiny. They have to sit in just a certain way. Sometimes people will have a lot of popping in their wrists that can be from some of those bones sliding out of place. We'll talk about those. Once it happens once, it'll continue to happen again, just like any other subluxations or joint dislocations. So again, thinking about the joints of the hand, it looks like a whole mouthful of words, but the names will tell you, excuse me, their exact locations or what they do. So if we're thinking about what these words stand for, I know it looks like a lot, not too bad. We're talking about the phalanx, or the phalange itself in each of these 3 separate phalanxes, right? So when you have 3 of them, you'll have a distal phalanx, a middle phalanx, and a proximal. Proximal being closer towards that midline and distal being further away. So the ones that are proximal will be closest to the rest of your body. The ones distal further away, this will be our proximal phalanx, our middle phalanx, and our distal phalanx. You're thinking, well, what would the joints be between each of those? Again, you just add the inter there, inter meaning between, intra within, so we don't have any intra joints. We can have intracapsular cartilage fluid, stuff like that, but inter would be between, the prefix. So a proximal interphalangeal joint would be your PIP joint. At the other end, a distal interphalangeal joint, a DIP joint. So these guys right here, this last little knuckle would be your distal interphalangeal joint. This one would be your proximal interphalangeal joint. And then if we keep working our way back to that other end of the proximal phalanx, this is where the phalanx and the metacarpals will meet. So it'll be your metacarpal phalangeal joint. Again, it tells you exactly what it connects, and we'll call that our MCP joints. The thumb, again, being a little bit different, you can see the other 4 fingers have 3 separate phalanxes in each phalange, but the thumb here doesn't have 3, it only has 2. So these ones, again, being our metacarpals, in the fingers, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, but in the thumb itself, just 1 and 2. So what joint do we get rid of? Well, it can't be proximal, it can't be distal if there's just 1, so that will just be the interphalangeal joint. So a proximal and a distal phalanx, no middle phalanx, can't be proximal, can't be distal if there's just 1, so it's just your interphalangeal joint at the thumb. If we're moving our way back a little bit further, more approximately, where the carpals and the metacarpals meet will be the carpal metacarpal joint. Sounds like a mouthful, tells you exactly what it connects. So on your worksheet from Monday, where you'll have to draw a picture, again, just an approximate location of some of those bones, the shapes of them, the joints of them, and the grouping. So carpals, metacarpals, things like that. Now of the foot, if you remember, the dorsal aspect would be that top part of your foot, that back of it. If you look straight down, standing up, the part that you see. With the foot, if we're looking at the bottom of it or the sole of your foot, that would be the plantar aspect. Well, with the hand, it's not going to be called that. It's going to be called the palmar aspect, which is pretty simple. You think about the palms of your hands, we already call it that. You might also see it referred to as the volar aspect. Means the same thing. Palmar is going to be used more frequently. So again, thinking about anatomical position, the palm side is anterior. If someone's facing you, that's going to be the front part that you're looking at. So the palmar side is the volar side, is the anterior side. Flip it over, the posterior side will be the dorsal aspect of the hand. We've already talked about motions a little bit. When we think about what causes these motions or these actions, well, what all can we do with our fingers? Again, the thumb a little bit funnier, but with our fingers, we can flex them and extend them, abduct them, so pull them away. If aliens are going to abduct you, they're going to take you away. Or we can adduct, ADD, adding to the body. Everything is based off of, this is kind of tricky, everything is based off of the third met. So your third finger doesn't really have the ability to adduct, but it can abduct either way. Just a stupid little terminology thing. When we think about the location of a lot of the muscles in our hand, even bigger people sometimes still have really bony hands, especially women and older women usually have really bony hands. So where are all these muscles that can allow us to do all these different things in the hand? They have very long tendons, but the actual muscle belly or that hunk of muscle is going to be in one of 2 muscle chunks of the hand, or it'll be part of that flexor and extensor mass in the forearm. So in the hand, on the thumb side, we have what's called the thenar eminence. That's going to be important to remember. Thenar, thumb, T and T go together. On the pinky side, we have, again, this little hunk of muscle called the hypothenar eminence. So another way to think of that, if you can't remember thumb and thenar go together, hypothenar, if I'm going to karate chop something, if I'm going to hi-ya karate chop with an H, that would be on the hypothenar side. just on that little pinky side. If that doesn't work for you to remember it, you can find something else, but I know that some people are taught that way. So again, muscle groups in the hand here. There are some muscles that will run between the rays of the hand. Some, again, very long tendons, and the muscles themselves will be in the forearm. So not super important that you memorize this picture. It's just to kind of show you what these muscle groups look like. So all these right in here being the thenar eminence on the thumb side. On the hypothenar pinky side, we again see this chunk of muscle. The lumbricals here, again, the ones running between the rays. You can't really feel those too much, but that would be, again, between each of the long bones. And then we can see just these white, almost ribbon shaped things. Those are going to be the tendons again. So the tendons of the muscles that will actually be in the forearm. On the dorsal side, again, just flipping it around, again, we really see a lot more tendons, not as many muscle masses. And I mean, that's pretty evident if you look at your own hand. There's not really any hunk of muscle on that dorsal side. When we think about the wrist motions and the finger motions too, so we've got wrist flexion, wrist extension. This is a new one. It's basically abduction, adduction, but we're going to call it radial and ulnar deviation. So it's kind of like waving, but it's not a shoulder thing. If you hold your forearm and your wrist, or I guess your forearm and your elbow steady, moving towards that radial side will be that radial deviation. Moving towards that ulnar side will be the ulnar deviation. This will be important when we're talking about restricting, especially a lot of motion. Your fingers aren't going to radially or ulnarly deviate. They'll abduct and adduct, but the wrist itself will radial deviate and ulnarly deviate. Again, same assessment, same history questions, especially with a lot of pain on the job type situations. If you can figure out from an ergonomic standpoint what this person does more often than not throughout the day, we can have a good idea of what is aggravating those conditions. So I know everybody kind of types now or, text, things like that, but think about your parents' generation or your grandparents maybe, when they're handwriting, this will work, when they're handwriting things, again, if they've got any muscle weakness or they're not using correct penmanship, again, if they're kind of, trying to write like this or, squeezing too hard on the pencil, that can again cause some muscle tension, maybe some tendinous overuse type things. If they're a cook that's stirring a lot or flipping things, if you work at a factory and you're doing specific functions with your hand, anything repetitive. So a lot of factory workers, people at Tyson, people working in a tree service, people stacking bricks, if you're doing the same thing over and over and over, the chances of having chronic issues, especially at the wrist, hand, fingers, is definitely going to increase. A lot of the times too, there are a lot of conditions that can be developed later in adulthood, like arthritis, rheumatoid arthritis, things like that, that will cause your fingers to kind of swell and be kind of sore. Your grandparents might have something like this. Again, part of arthritis is just part of aging, just an inflammation of the joint from some overuse sometimes. There's a lot of medications that can be ingested or put on topically. So your like icy hot type stuff sometimes can get some relief. Sometimes people will do like a paraffin wax bath where you just dip it in and it'll make it feel nice and warm and like a deep heater later on. So there's a lot of almost quick treatments that anyone can do on their own for arthritis pain, but there comes a point where it's time to go see a doc, get these things checked out. These are some of the several history questions they might really want to ask. Now, as far as observation, also very similar to the foot, a lot of things can be learned by looking at the hands themselves. So if you see any calluses on their hands, if they're manual laborer, manual worker, I've got some calluses here, looking at the fingernails themselves. Now, mine need painted right now, but if you see any bleeding under the nail, the subungual hematomas from dropping it on something, if you look, I'm going to X out of this PowerPoint real quick and open up Don't look at that one yet. A lot of vitamin and mineral deficiencies you can see with nail health if they're, yeah, so any of this stuff. So if they're starting to turn yellow, it could be a fungal issue. If you see ridges, if they're brittle, especially at the ends, if they get really flaky, almost like a biscuit, how there's multiple layers of it. If they start to club like this, it could be a heart or a lung problem. Again, if they're really brittle, we're thinking again some more vitamin mineral deficiencies. um Spoon shaped nails, which I don't see on this picture, kind of scooped, but it's actually called spoon shaped, and it really does bowl out. Again, there's lots and lots of stuff, even just Google image searching here, that can be found out about someone's general health by looking at their hands. Even just looking at scar patterns and things like that. If they're working in a place where they're exposed to heat for an extended period of time, do they have any burn marks on them? You can oftentimes tell if someone is a smoker by looking at their 2 or 3 fingers. Usually it'll have a little bit of some tar stains on it from them constantly drawing on their cigarette. It'll have some tobacco residue stains type there. If someone is inducing vomiting, sometimes we'll see it, it's called Russell sign. It's some scar formation on the top of the knuckles from the teeth hitting it if they're trying to purge intentionally. If someone is a nail biter, I've been a nail biter my whole life. My mom could never stop me. You know, as a baby, she would put socks on my hands, and you know, you put the nail polish on that's supposed to taste bad. It's I don't think a nutritional thing in my case. It's just an anxiety type habit. So especially kids that are chewing on their nails or picking on their nails, or, you know, chewing on their nail beds, pulling stuff off. It could be an anxiety type thing, just something they do just as a little tick. So again, you can tell a ton of health issues about a person just by looking at their hands. Now, on the flip side, you know, if you're getting acrylic nails done a lot where they have to actually take a Dremel tool and like sand down the actual nail, it can cause some bleeding and irritation. It's not a healthy thing to do for the nail itself, but after you get those removed, of course, they'll look terrible. But that's because of getting the acrylic nails and stuff like that. Similar to people's heels getting dry and cracked, especially in the wintertime. Same thing can happen with your hands, calluses, the same thing. There's a condition called dishpan hands, where there's a lot of irritation from the hot water drying the skin, and then just the soap itself causing some irritation. During COVID time, when everyone, yeah, here's a good picture of it. Well, it's eczema, but here they're calling it, oh, just cooks, dishpan hands. Yeah, some of that stuff, hand dermatitis, so an inflammation of the skin from something you're touching. During COVID times, when everyone was using hand sanitizer, again, the alcohol in that would dry the skin. It was cold anyway. It was, you know, April-ish. And it was cold outside, so you're automatically stealing some of the moisture from your skin because you're washing them a heck of a lot more than you used to. You're using an alcohol-based hand sanitizer. It's going to dry it even more. It's cold outside, so they're going to get more dry and chapped. A lot of times people would get just cracks in their skin, especially on their knuckles that were a little bit more dry, or right at the fingertips, and it would burn a lot more. So some people were saying, well, we know we need to use hand sanitizer, but we can't use an alcohol-based one. What's a safer, healthier option to help with my dry, cracked hands? You know, I don't want to put a lot of fragrant type lotions on them because that can irritate the skin further. And the skin is definitely not happy. It can be painful at times. So again, observation, this long spiel, observation, just looking at the hands, looking at symmetry, range of motion, things like that, color of the nail beds. Or is there any swelling? Is there any abnormal like posture and positions? And hands and toes are really just not pretty things. Everybody has at least usually a little bit of some crookedness, either moving straight up and down crooked or side to side crooked. Some have kind of like knobby joints almost. If you think about like Snow White and the Evil Witch had all these, really arthritic looking hands with real knobby knuckles and stuff like that. Again, hands are just not a really pretty thing, but you can learn a lot really easily. Palpation, again, for pain, for deformity, you're feeling for the hands if there's any deformity there. So if you have just punched a wall, you can break one of your mets if you're feeling down in there. Is there any tenderness right on the bone, tenderness right on the tendon? So as they flex, if they have pain all the way down their forearm, it could be from that tendon and it contracting and pulling on that, causing more pain. If there's pain, again, right in any of those large muscle groups there, it could be, again, a muscular type issue. Or if there's muscle atrophy in those nerve groups, it could be because the nerve that innervates them is weak and it's causing that muscle to atrophy because it doesn't tell the muscle to contract when it needs to, and it just starts to kind of palsy. That's very real. It happens in a lot of cases. So injuries and conditions that we will talk about, again, this is just skimming the surface of all the wrist, hand, finger conditions that exist, but some of the more common ones, especially in athletics, sprains, strains, carpal tunnel, fractures, dislocations, subluxations, subungual hematoma, same as in the toe. We'll talk about ganglion cysts, which are kind of gross, more cool than anything. You don't see anything gross. It's just the treatment that's really interesting. So first one, wrist sprains, we've already kind of talked about. Most common wrist injury, most of the time from an overstretch type stuff. So you go to push or block something, just an overstretch, it's going to have a little bit of pain with that. As far as prevention, sometimes if it's a fall, especially on an outstretched hand or a push mechanism, a wrist sprain is about the best case scenario because you could have fractures, you could have dislocations, it could go up to your elbow, it could go to your shoulder, it could go to your clavicle, it could cause a ton of issues, even synonymously. So a wrist sprain is really the least of your concerns. When it comes to the treatment of that, if they're having a lot of pain or swelling, treat the pain and swelling, and then oftentimes they're going to have difficulty moving it because that's what's causing the pain. Immobilization is easy for the wrist. A lot of people will, just put tape on the wrist anyway, just as a little bit of mild compression. It just feels a little bit better. There's a ton of over-the-counter type braces. You don't need a prescription. You don't need to get it custom fit. You just buy small, medium, large based on your glove size or your hand size through the palm, and just a little bit of compression just feels good a lot of the times. So again, there's a million different ways to tape it, brace it, pad it, a lot of options for wrist sprains. Carpal tunnel syndrome, we've talked a little bit about. This is going to be caused by compression of the median nerve and sometimes also the ulnar nerve. So this is something that has, I don't know if the stats support that it has become less common over time, but as there's been a lot more ergonomic changes in the shape of a keyboard or from typewriters to keyboards themselves, we've had maybe less incidence of carpal tunnel syndrome, or it's just maybe now expected. People understand the signs and symptoms and what to look for. So most of the time, this carpal tunnel syndrome, again, a lot of direct trauma to the wrist or repeated wrist flexion. With typewriters, you kind of had to plink down, so you're always in this position. Now, even if you're not typing properly, your hands will kind of be in some wrist flexion. So adjusting your chair height or your table height, they make little bumper bars that you can put under your wrists to really elevate them, keep them in more of a neutral position. They've got ergonomic computer mice to use. Again, lots of good stuff to help in the prevention of that. But a lot of the times when it comes to the irritation of the nerve, I'm going to bounce back in this picture real quick. You can see maybe, no, I think it's kind of buried, but in this area of the wrist is the literal carpal tunnel. So it's an actual tunnel that has basically sides and a roof to it. And a lot of your flexor tendons will pass through that. So of the 9 things that are in there, the flexor tendons are like 4 or 5 of them. The median nerve is one, some arteries, things like that. So whenever the median nerve gets inflamed, sometimes it'll swell. Well, there's nowhere for that swelling to go. not like compartment syndrome where it'll burst, but again, it's the irritation and the swelling that causes a lot of the pain. So how do you get rid of the swelling? You give it somewhere to go. You give it room to swell now. Well, what does that look like? And what happens is a surgical procedure called a decompression treatment, where they actually slice through the ligament that's there. It's called the transverse carpal ligament, to basically open up the roof of that carpal tunnel. Now, it's not going to be that the nerve's just starting to float around wherever. It's pretty locked in and stable in place. It just gives it some extra room if it needs to swell. Cortisone injections could be used. I'm not a huge fan of that because they may work, they may not. They may work for 6 weeks, 6 months. It's just very varied in what happens. So immobilization is going to be really helpful in calming down the irritation, but a lot of the times, by the time people are going to their docs and getting some imaging and going to physical therapy, that nerve is just so unhappy that it's almost better just to get that really quick surgery and have it immediately fixed than it is to wait for now the muscles in your hand to start to fatigue and then start to address it. So getting into some of those carpal fractures. So of those 8 tiny, tiny little bones in your wrist, the one that we'll talk about is called the scaphoid. So if you extend your thumb out all the way, you'll see these 2 tendons kind of become more prominent. Sometimes they're especially larger in men than women, but if you make like big hand, it'll really pop out. Mine aren't that huge, but you can see this little indentation that forms, this little triangle, this little groove between these 2 tendons. This part of the body is called the anatomical snuff box. So little history lesson, snuff is tobacco, right? So now if you put a dip in or a rub, that's snuff, but it used to come in powdered form, and it was very acceptable for women in any kind of social status to use this snuff, and how they would portion it out would be what they could fit in their anatomical snuff box. They would, I guess, scoop, I don't know, some into this little snuff box and then do their little bump of snuff, and the name just has kind of stuck. So this can occur in anyone. When we see scaphoid fractures, they're usually, again, that Fuchs mechanism, because as you extend the wrist, this scaphoid bone gets really compressed in there. So it's an abnormal shape anyway. It doesn't really have a lot of room. As we Fuchs here, we've compressed right in that scaphoid. It's going to cause a lot of pain, and the pain will be right in between those 2 tendons, right in that snuff box. So it's a telltale sign usually that that scaphoid bone is fractured. There might be some swelling, but again, it's going to be kind of hard to tell, especially if your snuff box isn't very prominent anyway. If it's kind of small, it might be kind of hard to tell that it's swollen, but it's going to feel almost heavy. It's going to be hard to grip things, especially trying to get in the weight room and really hold things might become very difficult. Even when it comes to immobilization, it's going to be very difficult, because if you think about its location, it's not got a lot of great blood supply. So similar to a Jones fracture in the base of the 5th met of the foot, it's not in a good location to heal. So in part of allowing it to rest is getting casted or getting immobilized in a wrist brace that's really going to keep you in kind of a slightly extended position, but a really neutral position to keep that artery getting blood to it. So your hand isn't going to die or fall off, but the bone might fall off. Well, not fall off, but just erode and die. So they'll continue, there's not a picture of it, they'll continue to x-ray it sometimes at every 2 weeks, just to make sure that that bone isn't dying. So what it looks like, these are hips. What it looks like on x-ray is where all the bone is lit up. There we go. Where all the bone is nice and lit up, this white part is going to be, and sometimes it'll turn kind of a grayish color too, will be where that avascular, so without blood supply, necrosis is going to be tissue death. So because there's no blood and oxygen, that bone is going to die. What'll happen over time, if it's not caught, is that you can again have the loose bodies. So the bone will start to disintegrate, and it could move and shear into some other structures, cause additional damage. And well, here they've put a giant pin actually in there to fix it, but the bone will kind of dissolve a little bit over time. So if you think about, we'll pull up this one. If you think about this one providing a lot of the stability at that wrist, if this is now gone, these other bones can kind of float around, and it's going to just make you not very functional in doing a lot of things. So prevention is going to be the key here. Now, if you can prevent a Fuchs mechanism, that's good, because that's going to cause a lot of other problems. But just being good at following doc's orders when he says, you really need to keep that brace on, you really can't be loading it, you can't really, do a lot of really heavy lifting in a lot of extreme extension, it's going to cause that bone to break and then be difficult to heal. Of the ones that I've seen two. They've both healed pretty well. One was a gymnast, and she could choreograph an entire beam routine where she didn't even have to use her left hand. So she could do all of her series, her like flips and jumps and stuff, either with her right hand or with no hands at all. So she was able to still compete the entire season. She went and saw a wrist specialist in Minnesota, I believe, and he was okay with traction on it, so kind of pulling on it. She could still swing bars, she just couldn't press on anything. And even then, it was just very limited. But yeah, she was able to do a whole beam routine without having to do any stuff on her wrist. Even on her floor routine, instead of doing stuff in wrist extension, she would just be on her forearms instead. So she still had a really successful season and healed really well. The other one was baseball. I'm not sure his exact mechanism, but I think he got stepped on or had his hands out sliding into the bag, something like that. And it caused him issues for a while, because it was, I think his catching hand. Yeah, so anytime the ball would hit his glove and he'd be a little extended, it would cause him some pain. But we see the next slide, hamate fractures occur a little bit more frequently, especially in baseball players, for two reasons. One, if you think about the shape of it, let me pull up Google. And if you think about the shape of the hamate has a little bit of a hook to it. So if you feel it's on the ulnar side, kind of right under this pinky bone, you'll feel maybe a little bit of tenderness. The ulnar nerve goes under the hook of the hamate, it glides right through. So when you fracture the hook, there's usually a lot of nerve damage. So either you feel that nerve damage right away, or you feel kind of nothing, and that's going to also indicate issues at that hamate. So usually it happens when someone is holding an object. So if this is my baseball bat, you know how it kind of is real wide at the top and then tapers down and then has that big ball at the bottom, the nub of the bat. If someone is gripping that bat too low, anytime that ball makes contact with the bat, it's basically going to press right into that hamate. So they're holding a bat and swinging, and all the force going into the hamate, or they've got their tennis racket, and same thing. They're usually holding something while they get that injury. So you can feel a lot of tenderness there. I mean, even if I squeeze hard enough, and you can feel mine pretty well, the hook at least, there'll be a little bit of irritation on that ulnar nerve. So hamate fractures occur from holding something. A lot of your scaphoid fractures, more of that Fuchs mechanism. It's something that, again, is not a terrible, terrible injury, but takes a while to come back from, because you use your hands a lot. So especially with baseball players, tennis players that have injured it from holding something, well, how are we going to get them back into the game and still prevent them from injuring that if they're still going to hold their racket or hold their bat? A lot of options. So you can make a donut, you could buy one, but it's easier to make a donut pad. So just a circle, again, shape of foam. So you put the most injured part on the inside of that donut and the foam around it. So anytime there's contact to that, the force is dispersed onto the donut while the inside structures are still allowed to rest. There's some compliance issues with wearing extra stuff on your hands just because you can't feel it as well. I completely understand that. It's totally valid. But again, if you cause additional trauma to that nerve, nerves are very slow to heal. So what's going to be worse? Having to have something on your hand for another 2 months, or potentially not having a lot of feeling in your little two fingers. To me, that's a pretty easy decision. This one is kind of exciting for a little bit of gross reasons. So wrist ganglions have multiple names to them. Sometimes they're called wrist ganglions, sometimes they're called ganglion cyst, sometimes they're called Bible cyst, and kind of for that same reason, sometimes it's called Gideon's disease. If you're unfamiliar with Gideons usually they're little old men on campus, but they can be anywhere. And they're usually the ones that leave those little green New Testament versions of the Bible. But Gideons were the ones that back in the day traveled town to town to spread the word of God, still do. And how it ties in with these cysts is a little bit of the historical expression too for how people would treat them. So if you think about how you're going to decompress a herniation or an outpouring of synovial fluid, so it's the normal fluid that's within the joint, starts to kind of pour out, and it gets trapped just right under the skin, so you get just a little lump. Again, it's not your styloid processes, it's not bone, it's fluid. So you can see it usually when you flex your wrist. They're usually on the dorsal side, sometimes they're on the palmar side. It is a genetic thing that's transferred from women to their sons sometimes. So if you've had one, you'll probably get multiple. And if you've had him, your mom probably has them too. They're usually painless, but they'll start as a fluid-filled type thing, and then over time they might get hard. Well, once they get hard, then it's really going to decrease motion and cause some issues. So a lot of people doing some, do-it-yourself surgery type stuff, we're going to decompress this guy. So what would they do? They would grab the largest book that they had, which in many people's homes was the Bible. When I'm thinking about books at my house, I've got stuff on my phone. So as far as book options, maybe a Previn Care textbook, who knows? But they would take that book that they had, someone would keep their wrist flat, and someone would just take it and smack it and cause that synovial cyst to burst, right? Now, it's not going to squirt out fluid. It will be dissolved and absorbed within the skin itself, but it may come back later on. Again, most of the symptoms come from the pressure and just the ugly lump that's on the back of your wrist, but it is a benign condition. It's not a lump of cancer. It's not, it's nothing really bad. You just might feel some pressure from the fluid that's around it. Now, if you're gonna burst it in your bathroom, power to you, but they can also be surgically removed. So draining it would be the aspiration of it, but they'll actually take out the sac of the cyst, because if it comes back, that's what's happened. The fluid has gone back into the cyst from continued herniation. And you'll have to, again, get kind of the nerves and the tissue, well, not the nerves, but the blood vessels and some of the tissue in the area kind of burned off in some of the prevention of it. So again, ganglion cyst, wrist ganglions, Bible cyst, Gideon's disease, all the same condition, just a little lump on the back of your wrist. My cousin and his mom both have these. He's had it a couple times. She's had it several times. We won't watch one, but you can pull it up on YouTube. People getting their cyst popped in like their offices. Someone's like, well, I'm gonna smack it. No, I'm gonna smack it. No, I'm gonna smack it. And they just smack it, and then it's nice and flat again. But here again, we just see those little lumps. Usually they're about marble size. They can get a little bit bigger, almost an inch. But again, they don't usually really get much bigger than a marble. If you had something growing on your hand like that, you probably wouldn't even let it get marble size. So after someone's been diagnosed with having had these, they usually know how to treat them. Okay, so our metacarpal fractures. So these are going to, again, be the long bones in the hand. You can break any of them, but sometimes they'll have specific names based on which specific met is broken. So if we have fractures of the fifth met here, so pinky side, usually associated with boxing, martial arts, improper punching, things like that. Again, this little pinky bone doesn't really have a lot of strength to it, especially if you're punching in weird positions or you're kind of sissy fist punching it, and you're taking a lot of extra load to that pinky itself. It's usually fairly easy to tell if a met is fractured because if you try to have them make a fist, they can't. So as those tendons start to pull on it, it's going to be painful. So they just can't really close their fist very well. If they do, if they are able to make a fist, you can have them kind of put it straight towards you and look at the knuckles. So usually the knuckle on the injured met will be kind of sunken down. If they extend their fingers out, it'll probably also be a little rotated on that side that it's fractured. So it might be non-displaced, it might still be in line, but if part of that bone is twisted, that'll be what makes the finger look a little twisted. Now, if you already have twisted fingers, you may not know, but usually there's a very acute mechanism. You hit a wall, you hit someone, you got stepped on. Same way as a lot of the metatarsal fractures, like a plant and twist or getting stepped on, the same thing can happen in your hands. Again, this is going to be something that even though it is a hand fracture or part of your finger, some people might think it's not that big of a deal, but again, you use your hands for everything. So especially considering the amount of nerves and blood supply that's in the hand, this is something that is going to continue to bruise and bleed if we don't do anything about it, and that's only going to make it a lot worse, especially older people where this is kind of thin skin anyway, but especially in older people, if there's any slip and falls or they're trying to get an IV stuck in their hand and there's bleeding under the skin, it'll get huge sometimes, like almost baseball size hematomas just right on the top of the hand from all the bleeding and all the swelling and pressure that's accumulated within that space. So it'll look scary, but that should be the indication it's serious enough to go to the doc, get checked out. Finger injuries, we'll talk about 2 or 3, but again, there can be several. These ones are a little bit more specific to fingers than toes. So you're not going to see turf toe or soccer toe type conditions as much as you would really see these two. And kind of the flip side, you're not going to see mallet finger, jersey finger in the toe. It'll make more sense when we explain it. So the 2 finger conditions that are very similar, one's called mallet finger and one's called jersey finger. So these are both super common, and it's the exact opposite of what happens. So with mallet finger, they will be unable to extend their finger all the way. So right at that right at that DIP, it'll just kind of be flexed a little bit. It'll be flexed a little bit. So they will have the inability to actively extend that last little bit of your finger. Well, what's going to really change if you now suddenly can't do this? I mean, not really a whole lot, right? So a lot of people just don't really choose to get it repaired. Well, in the short stage, you can fix it by putting on one of these braces called a stack splint. So what it does, it just braces it in extension so that tendon should be able to heal fairly well in place. Even though the tendons are very long, usually it's not under so much tension that it's going to snap down your hand and roll up in your wrist like your Achilles or a hamstring tendon would. So if you splint it in extension, it should heal fairly well. A lot of times people are getting mallet finger because they're trying to catch something. So they're trying to catch a ball and it gets like tipped off their finger. So because it gets injured in extension, that extensor tendon, because it gets injured in flexion, because it gets injured in flexion, so it gets jammed this way, it's going to cause that tendon to rupture, and now they won't be able to actively extend it, okay? It's the exact opposite of jersey finger. So usually you're trying to like catch someone as they run away, and in extension, it's going to basically get flicked up into a hyperextension. So you'll lose the ability to flex that finger on that side, and it was injured in extension. So if you say, okay, go ahead and curl all your fingers, well, if you can't curl that last little digit of one, if it's just going to stuck in extension, that's going to be a good indication that you've had jersey finger. Again, it's kind of a minor thing how much of your athletic career is going to be inhibited by your inability to move that last little bit of your finger. Maybe not a whole lot. So a lot of people let it go. I would get it fixed. Again, if its chances of healing properly, that window is very small. So if you don't do something about it right away, there's a chance that later on it's going to turn to surgery. And again, at the finger, you're using your hands all the time. You might as well just get it fixed right the first time than having to deal with it when you're 30, 40, 50 years old. The last condition has a couple different names based on how it happens in sports. So it's called gamekeeper's thumb, but don't think like the keeper as in like the goalie gamekeeper. It can happen with goalies, but that's not historically where that name comes from. So the story is that if you are a game hunter, you're hunting birds and other animals, that I think it's with pheasants or doves or maybe both. Sometimes when you kind of morbid, when you shoot them, they don't die the first time. So if you were to hold this bird in your hand, kind of like this, you would have to move your thumb this way to snap its neck. It's going to be one of the most effective ways of snapping their neck. I, of course, have never done that, but that's where that term comes from. So gamekeeper's thumb is an injury of what's called the UCL. What makes that also confusing is because we've already said 1,000 times, anything on the thumb side is radial. Well, there's a even more radial side of the thumb. So this would be the radial side. This would be the ulnar side. So if we think about the collateral ligament holding that in place, that ulnar collateral ligament, we have overstretched it. And that's what's going to cause that sprain there of the UCL of the MCP of the thumb. It's also called skier's thumb because if you're, as you can see by that picture, if you were skiing and you have your poles and you fall and you get that pole jammed within that web space, it's going to cause that to open up. And now you're going to have a sprain of that UCL. You see it in football, especially in line guys a lot when they're going up to tackle, their thumb's going to get pulled back as their hands continue on. So a lot of times, in addition to having their wrists taped and braced, they might also go through the palm of their hand just to get a little bit more stability. Now, you have to think about anywhere, and we'll talk about this when we get to taping and bracing too. Anywhere that tape crosses or forms an X is where it's going to be most supportive because that's where it's really going to check that motion. So if I put a piece of tape around my wrist and I put one through the web space of my hand, well, naturally, it's going to cross right on this ulnar side anyway. So as I try to radially deviate, that motion will be checked, right, or limited. So if I can limit the amount that my wrist has to move this way, I might also limit the amount that my thumb has to move. What happens sometimes, though, is that people put so much stuff in there that they kind of get club hands instead, and they don't really have a lot of motion of their thumb. So they may actually be causing more damage because now the thumb joints can't move like it needs to restrict that motion. So we see it again a lot with football just because it's going to be very difficult to wear this picture that's in the bottom, this Freedom Thumbkeeper brace. It's really bulky to wear. It's sometimes difficult to get to fit well because it's really bulky. And if I tighten it too much, then it kind of starts to curl at my hand. And its goal is not to get you walking around like this, but just to get it in a neutral position, right? Well, if you're right-handed and you're trying to write, with a pen, as you have one of these braces on, it's going to be difficult to grip your pen. So a lot of people don't wear this very well. You can, again, get it as more of a wrist brace that has little like thumb circle type in it. But again, anytime that you try to open up this web space, it'll be irritated or stretched. So if you can prevent that, it'll be helpful. Otherwise, it's just a wrist brace with a thumb hole. It's not going to be very helpful. Another time that I've worked with this was with cheerleading. So a girl was standing on a guy's shoulders. So as she was going to pop down, her hands came this way, and she was supposed to grab a hold of the guy's hands at his waist. So as she popped down, his hands were here. She was supposed to catch her own body weight. I mean, it kind of looks more like this, but so he's moving her down. She's trying to catch herself. Well, as her hands came down, her thumb, again, kind of overstretched too much this direction, and she got this gamekeeper's thumb condition. So because it's known as gamekeeper's thumb, but that doesn't tell us what it is. She was diagnosed with a UCL sprain, and I said, you got a UCL sprain. No, I've got gamekeeper's thumb. Okay, well, that's what that condition is. Made her a really nice brace like this. Problem was, it just never really got better. And I thought, going through all the questions. Okay, so I made this brace. You're coming in for treatment. How often are you wearing this brace? And she was an art student, and she said, well, I'm to the point where I'm doing my big final projects now. I'm not able to hold my paintbrush and move with all the dexterity that I need to with my thumb and controlling all my brush strokes and stuff. So I just don't wear it. I'm thinking, oh my gosh, you've been not resting it all this time. This could turn into something a little bit more serious. Because usually, again, there's not a lot of extra space for this to go. What can happen sometimes is that the thumb could actually get dislocated. Now, as a saddle joint, again, it's got a lot of mobility within that joint. So if it doesn't have somewhere to go, it's going to make a place to go and it will become dislocated. You also have, again, some larger ends of those joints coming together. So it's going to be important to get an x-ray just to rule out a fracture. Because if you just say, well, I just jammed it, I just sprained it, and it doesn't heal properly, again, you could have a lot of arthritis in that joint later on, even in that process of it subluxating, so popping out and then popping back in, you could have damaged some of that cartilage along the way too. So always best just to get an x-ray. They're pretty cheap. Your insurance is going to cover it if it's an acute mechanism. Definitely important just to get another opinion on those. So last slide, dislocation of the phalanges. So again, same as the toe. Sorry, same as the toe. We see these happen from a lot of times just accidental stuff around the house. So you're trying to close the cabinet and the door kind of hits you and you just kind of pull your fingers apart, or you slam your finger in the car door and it pops, or you get it caught on the shower curtain. Things happen. You have to think about the concave and convex structure of the bones. So if it's kind of like this cup shape and it gets moved out of place, if I just try to jam it back in place, I'm going to injure the condyles of this other bone. So there has to be some type of distraction type force to get them to line up and go back into place. So people sometimes say, well, what's the worst thing that can happen? So I dislocate my finger, I pop it back in on my own. I can move my fingers. That just saved me $6,000 in ER bills. What's really the danger? Well, again, in that process, you could have had an issue with the flexor or extensor tendons. You could have had a fracture actually within the bone from it kind of moving too much on that condyle, fracturing off. So even though it's non-displaced, it could still be broken. So it's going to increase the likelihood of it not only dislocating again, but of that fracture piece moving away from that initial injury. And who knows where it could go. It could get stuck again and cause more severe damage. So pretty important to get these checked out. Even if it is just a finger, it could cause a lot more issues and pain later on. Pretty easy to splint it. Even my cousin, well, what are they going to do? They're going to buddy tape it or tape it to a tongue depressor. I'm not paying that kind of ER money for something like that. But it's a good thing that her mom did talk her into going, because there was actually an issue at the bone. I think it was a linear fracture. Yeah, a linear fracture in the bone. So even when they did reduce it, they had to pay special attention that they didn't aggravate that a little bit worse. Again, you can buddy tape it just for a little bit of extra support. There's a lot of other braces that can be worn. In the process of it moving out of place, you're also going to injure the collateral ligaments on either side. So they're pretty ridiculous. They do make little finger sleeves that you could wear, just again, a little bit of added protection for that. Thumb stuff, again, a little bit different just because it is a different type of joint. But anything that we can do to stabilize it until a fracture has been ruled out is going to be important. Last thing is going to be the actual phalanx fracture. So not a dislocation of a phalanx, not dislocation at the MCP joint or your main knuckles, but of the finger itself getting fractured. Now, usually it's again an accidental trauma type stuff. It gets shut in the door, it gets stepped on. This can happen in sports from all kinds of things. Probably one of the most traumatic injuries I've seen. It was kind of gruesome, but it was more embarrassing for the kid than anything. It was at football in my sophomore year. I think we eat like ESU. I think we even do the same drill. I don't know what it's called, but you have an offensive guy and a defensive guy, and they kind of just try to push the other one out of the ring, like sumo wrestling. Well, what this guy did, he stuck his hands up to block the guy, and instead of getting him under his arms, his hands went up in his helmet, and this guy whipped his head, and in that process, it actually broke the distal phalanx on his ring finger on his left hand, because the guys, I remember it because the guys were giving him crap, saying like, oh, your wedding pictures are going to be all jacked up, where they take the hand pictures and, you're going to have your little hand, whatever. And as soon as it happened, I knew he hurt his hand, but he pulled his hand down, he started to take off his glove, and then he just started running. And I'm like, where the heck is this guy going? So chase him down, and I said, what happened? And he said, well, I went to take off my glove and I felt something in it. And we're like, uh-oh, what is it? And the meat of the finger had come off in that process, and he had broken the phalanx. So part of the avulsion had bone in it, but there just wasn't enough to really attach to it. So what happened in the ER, which the location of our stadium, it's a golf cart right away. We share the parking lot, the football stadium, and the hospital. So what they ended up doing was just shaving down part of that bone and just stitching it closed. So he did lose most of that distal phalanx, did have some of it, but again, lost most of the tip of his finger from that. So it's going to be pretty obvious with an avulsion. You'll see, again, a lot of bleeding. You may see the white kind of ribbon shaped thing from that tendon. Splinting, referring, antibiotics, a lot of that stuff is necessary, but very similar to that is another injury that's become prominent for kind of two big reasons. One, Jimmy Fallon had it and talked about it on air, but two, as the CrossFit craze has increased, it also increased the risk of this other injury called a ring avulsion. So Jimmy Fallon will talk about it. I'll look at it. I'll show you a picture. But what happens, it's usually a phalanx or phalange fracture, dislocation, but also what's called a degloving situation. So if you think about the hand wearing a glove, as you start to peel that off, it's the meat of the bone that gets, or the meat that gets sheared from the bone in this degloving type issue. So in CrossFit, if you have, or any kind of lifting, if you have a ring around your finger and now the bar gets pulled, what can happen is it can pull that meat essentially with it. Good thing, bad thing with that, it can be reattached, but usually they have to cut the ring off in the process. And it is a very delicate surgery. You're thinking tying back blood vessels and nerves that are very, very tiny just on the tip of your finger. So we'll watch a couple minutes of him explaining that and then hop to something else.
I can't tell you how excited I am to be back and seeing you guys right here. What a crazy break we had. 2 week break, 2 weeks. Yeah, so basically what happened is I tripped and fell. Like a braided rug that my wife loves. I came with burns to the ground. And I tripped and fell, and I caught my fall, and I'm getting up, and my finger is stuck. So I go, oh my god, my finger is the lamest thing in the world. It's like completely looks fake. It's like a fake, like a cheap horror movie where you see like a broken finger. It looks like that. That's what it looks like. So I go, I wrap my hand in a towel, and I get the cat in the emergency room. I go, I put my finger, and they look at me, and go, well, you didn't break the finger. It's a thing called ring avulsion. AVULSION. If you Google it, the graphic images. Don't Google it. But ring avulsion, it's a real thing. So basically, what it is my ring got caught on the countertop when I was going down and stuck there and pulled my finger up. Trust me, I'm like, wait, what? I didn't even look at the thing once I go, I don't even know what's going on. So I go, can you fix it? They go, oh, no, you gotta send me somewhere else. So we don't even do that. No, really, this is like microsurgery. This is like the thing. So I had to go to, I was at Beth Israel. I went over to Bellevue Hospital. This amazing doctor, Dr. David Chu. Dr. Chu is his name. Awesome doctor, comes in with a bow tie and cowboy boots. Like,
Northwest Line.
that's my
Yeah.
doctor. Yeah, that's my guy. I knew it when he walked in. I go, that's my finger. Say my finger. Apparently the odds aren't great with these things. This happens a lot, and the odds are not usually they just gonna cut your finger off. So I was gonna lose my finger, and I was like, wow. So this guy did surgery for like 6 hours, micro surgery. So it's like under a microscope, he had to take a vein out of my foot. The craziest story. You gotta be. I mean, I didn't know this was happening because I'm knocked out at this point. Yeah. And so he took a vein out of my foot and put it in there, and if you attach it, veins only work one way. It goes this way or that way. So he has to make sure. You're so happy I'm not your doctor.
Vein it this way.
Veins go this way or that way. Here, get this guy. Yeah. So you have to remember which way, and you have to reverse it and make sure. And then if you're putting it together, if you do one missed stitch or something like that, the vein closes up in a few. And even you screwed up, it's not gonna happen. And he did it. He saved my finger, and now you can see it's pink on the end. It was white like this color. And so he saved my finger. I won't get feeling back for 8 weeks, he said. I was in the ICU for 10 days. And I gotta say, the nurses over and the doctors at Bellevue Hospital, thank you so much for taking care of me. Oh my gosh, I love you guys. Job. Tough job. You guys are rock stars and just awesome people. Dr. Reese too is great. Dr. Patel, Dr. Wolf too. But I started losing it halfway through. Yeah. Because you just sit there, you're in a room, and I started reading books about the meaning of life. And
What else you gonna do?
why go? I don't know. I always wanted to read that. I just never had the time to read that. This is the book I read, but I had a Kindle.
Okay, well, anyway, that was his situation. If you don't want to see gross things, then don't look. But again, like he said, sometimes the odds aren't great in getting everything stitched back together because it is so delicate, so friable of tissue. Usually the ring breaks in the process where it has to be cut to be removed. So got some gross ones, so look away if you don't like this. But we see, especially in this picture, the ring's still on it, but again, it's just sheared everything off. One of the also gruesome ones where it's at the top. Ooh. This one. And the white thing that's kind of been pulled out, again, that's the tendon of it. So the tendon all the way in his forearm the whole thing was ripped out. So I don't know if this guy was in a situation to get that surgically fixed. Again, here, the piece of tissue that was lost, they x-rayed that bone, and here's again that distal phalanx in the x-ray. So fracture for sure, avulsion for sure, a lot of tendon damage, nerve damage, things like that. So the safest thing to do is just not wear a lot of metal, especially wedding rings, wedding bands, because they'll provide more resistance. But the silicone ones have been the craze, and you can get, I think, like 4 for $8 at Walmart. So that is another option if you were definitely going to wear your rings. Silicone one's a little bit safer, but any kind of extra thing on your hand that can happen with. Last one again, subungual hematoma, same as a toenail, bleeding directly under the nail from some type of direct pressure. You've smacked your finger with a hammer, you've gotten stepped on, you've slammed it in the car door. It is bleeding initially, so it's the active bleeding that causes the hematoma, the collection of blood within the cavity. And then if you are going to drain it, it has to happen sooner rather than later, because after that blood has clotted or coagulated, it's not going to be able to escape. So a battery powered cautery, again, it's that little heat needle type thing where it's a one-time use. You flip that battery on, it gets red hot, you just touch it to the nail, it'll burn a hole through it, it'll smell like burnt hair because it's burnt collagen. Going through that nail, sometimes blood will escape out because of the decrease in pressure. Ultimately, the nail could still die just because the nail bed up here is where all the growth comes from. So it can start to lift up from that, what's called a nail plate, if it has bled too much. So a lot of the pain comes from the pressure. So as it's building within that space, it's pressing on those nerves even more. If you reduce the pressure, you've reduced a lot of that pain. Unfortunately, then if you do drain it, you've got an open wound. So you have to be mindful of that, the bloodborne pathogen exposure, proper disposal of stuff in the bloodborne pathogen box. If you're using a needle, a paper clip would be better, but if you're using a needle or anything like that, put it in the sharps container. Again, in some cases, you still will lose the nail, but it at least won't be as painful. And then it'll take a really long time until that just kind of grows out with that. It can kind of be like a status bar, like the progress of it growing out. You'll see some of that bleeding start to grow out onto the nail. But that's all we will do for wrist, hand, finger, thumb conditions. Again, there are several other ones that we could talk about, but these are the most common ones in athletics. Your jersey finger, again, you're pulling away from something, you've injured it in flexion, in extension, and it cannot flex. So it would look like this if you try to get them to flex. Mallet finger injured in flexion, unable to extend just that and I can't really do it, unable to extend just that last little bit. So it would be that tiny, tiny amount of motion in that most distal aspect of our fingers. We've got our DIP joints, our distal interphalangeal, our PIP joints, our proximal interphalangeal, and our MCP joints, these main knuckles. That would be the metacarpal phalangeal joint. At the thumb, we have a distal phalanx and a proximal phalanx, no middle phalanx. So this can't be a DIP or a PIP, it's just an IP. And then this, again, is still one of your metacarpals. So this is still an MCP joint right here at the thumb. Metacarpals here, we've got 5 of them. And then our carpals here, 2 rows of 4, make 8 bones. The scaphoid is going to be the one in this anatomical snuff box. The hamate, again, is the one where there's a hook to it. It has the ulnar nerve that runs through it. That can be damaged. We didn't talk about another bone called the lunate. Sometimes, especially after the scaphoid dies, that lunate, it's kind of cup-shaped and it can spill and kind of pop and sublux over. So sometimes you'll have issues with those. But again, hand stuff, even though it is just a finger, just a toe, just a knuckle, it can be very serious if left untreated. So I will see you in class on Friday. Don't forget to bring your handout from Monday with the draw on your hand type stuff, homework quizzes, and then we'll go ahead and do our review Kahoot. Be sure to ask any questions you have, and then it'll be that next exam. So you're still able to drop the lowest exam score. Homework quizzes will also be really beneficial in your studying. And of course, let me know if you have any questions. See you in a couple days. Thanks for watching.